cure for one because we've always had cure for one. We've always had great treatments for specific things. But what I'm going to be talking about, at least for the first half of the talk, is elimination of prostate cancer for all. And I don't think anyone really, I don't see this talk given. I've given it at 3 hospitals, and people were kind of blown away by the possibility that it's kind of there for the taking, but can we really make the changes necessary? Can we seize the day on this? Because it actually is possible, I think, to make the case that you could eliminate prostate cancer completely. And so then the other is not quality of life. Everyone wants quality of life, but there's another thing. So if you go to surgery and afterwards you have some urine leak, you'll be kind of appalled, upset, depressed for some time. But over time, if you talk to the same person a year later, even if their incontinence is no better, they will see it as different. They will adapt to it. They will be part of their life. It won't bother them. So quality of life is you have this symptom and how much bother do you feel about it? You can fill in the blank. It could be erection dysfunction, devastating at first, but a year later, okay, I've worked around, got some workarounds for that. 5 years later. So the quality of life is always about the bother. I see that as a kind of a weak form of assessment. What you really want is full function preservation. You want to know that your urination and your control is exactly as it was before treatment, that your erection quality is exactly as it was before treatment, and any kind of rectal function is exactly as it was. So how close are we to true function preservation? Because the goal would be get rid of cancer completely and preserve your function just as it was before. So I'm going to put this out again, prostate cancer elimination. I just kind of want to burn that idea into your brain as a very, very real possibility. And it has eluded us for a lot of reasons that I'll go into tonight. So how would this go? I used to give two titles for my talk. One was prostate cancer elimination. The other is kind of more of the same. So on top here, if you don't have screening, and remember in 2012 they took screening away, they advised against it. This is a disastrous turn. And you end up with non-curative treatments because men would progress and be diagnosed very late. They would progress to non-curative condition, and they could easily burn through in the current era $500,000 to $1 million per patient in these new exotic drugs that are not curative. They buy a few months, sometimes might even buy a couple years, but they are not curative. And then on the other hand, screening as it was practiced, $100 for a PSA, maybe it's gone up a little bit, but then 50,000 to 100,000 for treatment. So you get the idea. You're over here, you're in this $50,000 range. Over here, you're in $1 million range, but you're not actually curing the cancer. You're just buying time. And so if all went well, you could have screening, you could find these cancers early. You would give aggressive curative treatment. But, we've got to check off this list, and you're going to find not all of these things are in place, even though they are completely possible. So we need to kind of go through this. So PSA screening, the segments of my talk, PSA screening. Second is cure and function preservation. This is kind of my wheelhouse, but I'm going to de-emphasize it a little. I sent my 2020 talk to Jim, and I can get you a link for that. That went through in gory detail. But then prostate cancer elimination. How close are we? What would that look like? So the barriers to prostate cancer elimination, the task force recommendations in 2012 were quite troubling, but there is primary care adopted this. They stopped screening across the country, internists, family practitioners. Virtually every primary care doctor took this so much to heart, it created a disaster. And then you have NCCN guidelines that doctors may follow, but there are problems with those. If you try to find the best treatment, it's a little bit difficult in NCCN guidelines because they're trying to appeal to all the different doctors out there, all the different things, and they don't really want to offend anyone, even though there are some marked differences in how these things play out. Age bias, racial bias, dose escalation or not, recent technical advances. So there's a lot of pieces we would have to get in place for prostate cancer elimination. But there's really, it's there. Now, barriers to quality of life. This is, again, where I've done a lot of work. Limit ADT, limit ADT, limit. This is hormone therapy, and there are incredible new studies that suggest we can limit ADT and not give up anything. But then we go to MRI-based planning, and you're talking about sphincter length, nerve bundle anatomy, vessel sparing update. And so there's all kinds of things that were in the 2020 talk, and I have a good recording of that with good sound quality. I'm going to lean on that. I'm going to mostly just say limit ADT. What's the new data there? Very exciting. Because ADT, if you wanted to improve quality of life, you would limit ADT. Then vessel sparing radiation we'll do a brief update. So if we talk about PSA screening, again, the task force really hit us hard in 2012. They said there's no mortality reduction from screening, according to the major study. So any screening test has to reduce mortality. Otherwise, you're just drawing blood, doing a test. If it doesn't reduce mortality of a cancer, it's really, you can cross it off the list. They believed from one study, ignoring all the rest, that screening did not lower mortality. They also said what happens with screening is you find a whole bunch of low-grade innocuous disease. Then those men are told they have cancer, they have surgery, they end up impotent, incontinent for nothing. Really, they're over treatment. So they called this, though, overdiagnosis, and they stopped screening because this is such a problem for them that they wanted to stop all screening. And they said, we have the license to do that because there was no mortality reduction. We don't really lose anything. Screening didn't work. Let's just stop it and avoid this problem. So I'll try to convince you that those were disastrous mistakes. A couple of years ago, I saw a 52-year-old African-American in consultation who presented with Mets and a PSA over 200. That was his presentation. Never had a PSA before. He was accompanied by his father, who was screened 25 years earlier and cured prostate cancer. When can we start his radiation, he asked. And, what followed was the saddest conversation in my whole career, I think, because his father came along as kind of coach, son, it's going to be fine. I had this before they found my prostate cancer. And his father had no idea that his son was essentially doomed. He had metastatic disease. And so, this was a sad day, but what made it 10 times as sad is the fact that in 1990, it had been recommended that Blacks with family history start screening at 40. This came out of Wayne State near me in Detroit. They have a lot of Black screening, and they were saying, hey, we're finding bad cancers in men 40. At that time, we started screening at age 50 for whites, but this was policy. The American Cancer Society advocated for Blacks, made that policy, and if it had been 30 years ago, he would have been screened at 40, and very likely would have been found much earlier. But Blacks, it's a plague on the Black race. The American Cancer Society has put this out very clearly. And but practice 30 years ago, not just for Blacks, but for whites, was superior to current. And I defy you to tell me any corner of medicine where medicine was drastically better 30 years ago. I don't think you're going to find it. This is one, though, for sure. So what we did in 1994, we were interested in this question, Dr. Sandler and I, and what we saw was that we were trying to find out because Blacks were slow on the uptake of PSA screening, but then within 3 years, due to a whole bunch of pushing, we had churches come out to our practice. They really realized that this was a terrible disease for Blacks, and they started having these screening studies, screening days. And so, but what they found is, it's kind of amazing that very quickly the PSA diagnosis for both Blacks and whites was 10, which is amazingly low. And that was real progress. We kind of published this paper and said, wow, can you imagine that Blacks, first of all, had an aversion to screening, had aversion to rectal exams, lots of barriers for them, and they were able to overcome those barriers. And we were kind of finding them early, the ones who really needed it the most. Now, where are we now? after all that screening stopped. 2019 to 2024, blacks at diagnosis, their PSA at diagnosis is 26. I hope you are shocked by that. That's high risk disease. The average black is diagnosed at high risk, and not very far behind at all are whites. They used to be 10, now they're 18. Now, if we updated this further, they're probably 20, because the message has still not gone out to do PSA screening. So many of you were diagnosed with PSA screening, but if you don't do it, is a massive price to be paid. And so if we look at the PSA screening, we have three eras. What was it like in the world before we had the PSA 40 years ago? What was the PSA? What did the PSA era do? And then what's the policy area? So I'm going to go through these. Pre-PSA era is a little bit hard. The literature is not as pretty. These papers, you kind of look at them and you realize how far papers have come. But this is a good single institution study where you go from 74 to 83. That's a 10-year span in there's no PSA at this point. And what you have is mortality for blacks. 40% of blacks who were diagnosed with prostate cancer died of it. Again, 40% who were diagnosed with prostate cancer died of it. 20% of men. So most of you have kind of lived in the PSA era, and you've kind of gotten used to saying, hey, no one dies of prostate cancer. Right? You find it early, it's innocuous disease, but this tells you how bad it was. Well, it doesn't tell you how bad it was. It was way worse, because though the 40% and 20% are shocking numbers to us, the reality is virtually all aggressive cancers progressed to incurability and death. So if you were diagnosed with a high-grade cancer in the pre-PSA era, you were doomed. And it's hard to even imagine that and fully understand that. So you have all these low-grade cancers that have always been there, just as we have that in breast cancer. We have DCIS in breast cancer, and that's a kind of a low-grade cancer we wish we wouldn't find, but it makes all the statistics look good, right? If you look at the zero website for prostate cancer, they talk about 95% survival. It's because they're diluting the bad stuff out with good. So this is the whole picture of prostate cancer. For blacks, 40% dead, but they had 60% that were less aggressive. For whites, 20% death. So what happens when you include all these in your statistics? You get this really very flowery picture that, it's 40%, but in reality, every one of these high-grade cancers died and were doomed. And so here's how it looked. If you had a Gleason 8 or 10, there was 90% mortality. So I want you to remember that, right? I hope that's a little bit shocking to you, because these have been around forever. They're not the most predominant, but Gleason 8 to 10 is a high-risk cancer, and every single man diagnosed before we had PSA was doomed. And so how did that happen? What was happening? Well, this blue thing is a prostate, and you see this little speck. That's a tumor growing in the prostate over decades, but this is undetectable progression. It's going on in his body. No one can feel it or find it. And then finally you reach a point of clinical detection where the cancer grows, and then right after that you go metastasis and death. You had no real way to find it until clinical detection, and by then it was too late. They just move on. And so that's why 100% of these men died. Now, if you look at this is a little bit confusing, but this gets back to that 40,000 deaths. So this is the 40,000 deaths. This is patients that were, 20 years earlier, that were going to be coming through in 2012. And if you watch these come through, there's this march, right? Death march. Remember, you saw that flat line every year there's death. They just progress through palpable, local, locally advanced, metastatic, nothing to stop them. And you end up with this stacking of caskets. Very hopeless situation. But an amazing study took place in this time. Thousands and thousands of physicians stored serum in 1982. And this was one of the really brilliant studies, because it helped with a lot of things. They could look back. There was no PSA in 1982, but as these men went on and were followed and they developed lethal prostate cancer 10 years after this, 15 years after this, they had the capacity to look back at that blood and say, could we have found this earlier? So they ran PSAs after this, after they were diagnosed with lethal cancer. And what they found is, kind of astonishing. A lot of these cancers were detectable 10 years before they were diagnosed. So these men were diagnosed, they pulled this blood, and they realized, my God, your PSA was elevated 10 years ago. We could have known that. We could have detected it 10 years early. And 10 years lead time is a lot. By comparison, if you look at cervix cancer, Pap smear gives you 20-year lead time, but you don't need 20-year lead time to cure. 10 years, finding it 10 years early is a big, big change. So this was a proof that PSA screening provided a never available opportunity, right? You had all these cancers rolling right through all the progressions, nothing to stop them. By the time you could feel them or by the time they affected urinary function, it was too late. So a very desolate picture. But then you get to the PSA era and things really change. So this is that picture again. This is that, prostate with a tumor in it. And now instead of this long period where you cannot find it at all, it's undetectable, you've got PSA detectable. You can pull it out of line, right? You can find these cancers, pull them out of line so they don't get to metastasis and death. The other strategy that I kind of got pulled into, and my chairman, most of the world pulled into, was one that seemed to make sense. If we intensify our treatment right here, we can stop these dead in their tracks and stop the mets that way. So there's these two strategies: improved therapy, and I mean, it was an arms war, right? Neutrons, protons, brachytherapy, all the things I did to intensify treatment to try to stop these and cure these after they were, admittedly very late in the game. But the other strategy, early diagnosis, was very controversial. People didn't know how this ever got launched with the intensity it did is kind of amazing. But anyway, if you ever have oncology investor advice and you're trying to choose between screening and early diagnosis, always choose screening, right? That's how most of these very common solid tumors have become curable. Better treatment, testicular melanoma. There's been miracle treatments, and you're going to see in the next few years with immunotherapy, you're going to see miracle treatments, but that takes longer. Screening has always been the path. And so now let's look at that death march. You've got these guys that are going to, in 2012, they're going to arrive at the finish line here. But what's happening? See, that box is emptying out. You've screened them, you got PSA, and now instead of 100% death, you got 50% death because you pulled them out of line, diagnosed them way back here or way back here, and these can still be cured. So PSA was truly a miracle opportunity it brought. And you can see it here. This is whites to the left, blacks. Stupendous drop in Mets. So 1990 to 2000, in 10 years, you had a 70% drop in number of men coming in with Mets. In blacks, almost as good. This shows that blacks adopted screening. But as in all of these things, if you look at whites versus blacks, 66% or 66 per 100,000 versus 170 per 100,000. They literally have twice as many cancers, twice as much metastasis. Again, you can't emphasize it enough. They are really stricken and doomed by their genetics. It's not, though, access, because again, these guys were getting PSA screening. It's not access. It's simply bad genetics for cancer. So this is a one, whenever I have a star, I want you to try to kind of burn this into your brain. But this is mortality, and this is the PSA era here in purple. So you can see black mortality here peaked, and then in 20 years from 1992 to 2012, it dropped by 50%. Again, think about that, 50% drop. Whites, same thing, 50% drop in 20 years. That is really a staggering effect, right? Who can argue against that? It's a population effect. It's not I mean, that's the ultimate test is, can you decrease the mortality in the population? Here's the kicker, though. That 50% drop occurred when less than 100% of the population was screened. So follow me on this if you can, because if you look at that graph and you see that 50% drop, it's an underestimation because we actually think less than 100%. We know less than 100% were screened, but what would have happened? So how this works, you look at 50% drop in mortality, you're right here. But you've only got about 65% of men who were screened. So if you extend this to 100%, you dropped mortality to 80 by 83%. Again, I think if you had a headline that said you could drop mortality of breast cancer by 83%, it would be in every paper, and it would be in every paper for weeks and weeks and weeks. But this was kind of lost, unfortunately lost in the shuffle by the task force. So what do we have any direct evidence though? Let's say you did have 100% screening. Do we have any direct evidence? Well, if you look at one of the trials, these were randomized trials where half the men on the trial were screened, half the men were not screened. These were very huge studies. I mean, thousands and thousands of men. And the European version of this would be the mortality up here. And this is what happened to the mortality when 100% were screened. Again, you're going to see this number again and again, 78, 80%, some ridiculous drop in mortality when you screened 100%. So what's the theoretical limit? Well, it's probably 90%. You can drop it 90% because some 10% of cancers just simply do not make PSA, and they're going to have to be detected another way. But can you imagine that it's pretty apparent that we could probably drop this 90% with just what we know already? So if we look at 2012, how did the disastrous recommendation from the task force come about? Well, we saw that SEER, that's that big graph I showed you with the star on it, 50% mortality reduction, greater benefit in blacks, corrected to 83% if 100% were screened. Göteborg don't worry about the names. This is another randomized trial, very pure. This had 78% mortality reduction if you did it in the right age group. So they split up by age groups. 55 to 60-year-olds had a 78% mortality, and they were just screened. But this is a randomized trial. It's a very stringent test, right? Half the guys were screened, half were not. And then the PLCO, the American study, sticks out like a sore thumb, right? 0% mortality reduction. You have to ask yourself, what the hell is going on, and why did the task force adopt this, look at this and say, this is the true answer? Well, it's a very big study. They basically said this study was small. It's like 1/10 the size of this one. Most of the time, bigger is better. And then SEER, they just said that's a population study. You have no idea what actually caused that drop in mortality, even though it's very impressive. So they ignored all but this study. And in 2 years after that, in 2012, they found out that this study was completely contaminated. Both arms had full screening. Because imagine in this country at that particular time, trying to tell men to not screen. You're on a control group, and everyone and their brother was getting screened with PSA that was in the papers. So you're going to just sit there and say, I'm not going to get screened. So as it turned out, all these guys who were supposed to be the control arm were screened. And so, of course, there was no difference between the arms. And that came out in 2014. The group, this PLCO, the authors of that group said, we are sorry this error completely hid the benefit of PSA screening and resulted in disastrous policy and unnecessary deaths. Well, if you know human nature, people are not willing to turn around and say this, what a disaster. And they actually kind of remixed their study and somehow got it published. This is like one of the really hideous moments in evidence-based literature. They should have been repenting in Dust and Ashes. This is a terrible paper, says nothing about the benefit of screening, and yet they tried because they had grants, because they had really literally hundreds of people on the project. They tried to rescue it, and that's unfortunate. So then After that, another study came in with huge study with randomized trial. That's a randomized, that's what everyone goes on, right? A randomized trial that showed this large mortality reduction. And again, now it was really catching up, you would think, with the task force because they were looking at all this. Their key study was contaminated. Now they've got all this evidence mounting that screening drops mortality dramatically. What did they say? We are sincerely sorry we botched this analysis, ignored critical data supporting profound mortality reduction, and need to overturn our recommendation. Well, they didn't. They just kind of fell silent, as if none of this really was that big a deal. I mean, this is, again, what was going on there. And so the thing that they banked everything on is you're finding all these early cancers. Guys are becoming maimed for cancers that are not cancers. We have to stop it. They still said you have to stop screening. And so the challenge of minimally aggressive cancer, though, did not come with PSA screening. You saw it earlier, right? We had, 2/3 of the cancers diagnosed in any group are these lower grade non-aggressive cancers. And the key is do what they did in Europe. Don't treat these men, watch them. And all of those studies, most of the studies on watchful waiting were completed in the pre-PSA era. That's a little bit shocking to people because they think all overdiagnosis, finding all these low-grade cancers is a function of PSA. That's why we need to stop screening. They've been around forever. And in fact, we knew you just shouldn't treat them, right? Watchful waiting. So overdiagnosis in the PSA era, though, is early diagnosis. So everything that happens, you start screening. Remember those cancers progressing, you're going to find everything early. You're going to find the bad ones early. You're going to find the bad ones 10 years early, and you're going to find the not so bad ones early. And so what happens when you screen, you're going to find a lot of these. No one dies of these. But you're going to get this big burst of what they called overdiagnosis, and they thought it was a disaster. But later it goes away. And so the idea of overdiagnosis was really kind of a crock. And so what did happen though when you screen people, you found a lot of moderate and poorly differentiated, but you didn't see a big bump in these low well-differentiated cancers. They're kind of flat. You get lots of poorly differentiated in blacks, lots of moderately differentiated, but all of these are important to know, and that's part of why you had such a dramatic drop. There was one study, I apologize for the detail, this is a little too much detail, but they looked at a randomized trial, and what they saw is on the screening arm, they had that bump, non-lethal cancers rose, and then with long follow-up, the non-lethal on the non-screening arm caught up. So this is how this looks. In screened arm, you had this big burst of low grade cancers, but then it dropped because it's like a fished out pond. You pull all these out early and then it drops. The number of those cancers dropped. But when they followed for 20 years, they found the non-screened arm had these low grade cancers. They've always been there. You saw it in the pre-PSA era. They're there. We wish there was some way to not find them. But the key is if you find them, don't treat them. And so this idea that there's overdiagnosis is wrong. It's early diagnosis of non-aggressive cancers that needed to be recognized. So unfortunately, this is a little piece of delay, deny, defend. This is the motto of the insurance companies, right? And it's a fight a lot of people are fighting, very bitter fight. Delay approval, deny approval, defend not approving. And this is kind of like if you want to think of PSA screening cessation as a giant cutout. It's a cutting out a whole group of the population. Instead of one by one fighting with you on the phone, let's just say stop screening. And it's a disaster. And it was a way of limiting costs, right? A lot of people believe the insurance companies had a big say in this policy. Hard to believe they didn't. But it's like Tuskegee, right? Remember, men were with treatment for syphilis was withheld from patients, so they were observing the natural history of a lethal condition while withholding a proven remedy. I mean, this is one of the saddest chapters. This is the first thing you learn in medical school about Tuskegee and these men who were kept on this study even after penicillin was found. Well, Tuskegee V2 includes whites and blacks because we're seeing, as I said, we're seeing many blacks and many whites come through and too late. And, this is an avoidable disaster. So currently 10 to 15% of my practice at any time has metastatic disease at diagnosis. That's sad. There was 20 years there where we didn't see this at all because you were finding these men early. And was this an honest mistake? Well, I don't want to get too much into crazy theories, but what happened before they issued this is there's a very famous statistics group that helped them with all of these studies called CISNET. You don't need to know that. But mysteriously, they said, we're going to take over prostate. We don't need your help on prostate cancer. CISNET was coming out with papers saying screening is very valuable, and the task force dismissed them. So I think that is like a smoldering, that is evidence that they were consciously trying to cut men out of the pie, old men. There was this horrendous bias. And again, I think you could say, well, they're diagnosed at 70. If you're 75 back then, you're going to die by 80. Why do we want to find these? And that was sadly a terrible misconception. So one of the doctors I work with, Dr. Winfield, was an incredible, wise soul. And the minute this hit back in 2012, he basically said, they know that what they are doing. Men do not advocate for themselves. And so I kind of thought about that again and again. Well, I don't know. They seem to advocate for themselves, don't they? I can tell you one man who was a victim of this advocated for everyone. He fought till the day he died. But men take it in. They're brave, right? They're long suffering. They're patient. It's like women and children to the lifeboats, men stay here. You take pride. You almost take pride in the fact that you don't complain, right? Even though this is one time you should have complained. But what happened when mammogram screening was interrupted, and all they did is say, we're going to stop screening premenopausal women. What happened? The Congress stepped in and said, no, you are not. So obviously this is a kind of crazy bias because PSA screening was the whole shebang. It wasn't just in a group and say really old men shouldn't be screened. They said no one should be screened. Shocking. But what happened? What happened is more shocking, right? Where was the Congress? What's going on? Where was the Congressional Black Caucus? You got black men dying at twice the rate. And they said nothing, did nothing, didn't even notice this. Where was Obama, right? Our big advocate, liberal advocate, whatever you want to call it. Where was he in all this? And so I think it's, absolutely shameful that no one came forward. But the logic, there's something deeper going on. Men are expendable drones. I told one of my patients that, because, he said, I got to tell my wife. So he ran home and one, but it is only partly humorous, right? Because the idea here is they wrote off old men. These are old men. Why screen? Why do this? This was a crime against humanity that will catch up with them. It's catching up with us right now because I'm seeing men diagnosed way too late. And then another one of my colleagues said, if Black lives don't matter, what makes you think Black deaths matter? So, again, no matter what your political persuasion, to see a young man die unnecessarily and his father, who was screened, not die and come in and realize the tragedy of this, I don't care what your persuasion is. This is not acceptable in America. And, one of the things I always say, the gift of a medical career is the fact that you meet every tribe and every race. And I can tell you after meeting, I mean, I never, on my street, we had a all white street. There was one street many, many blocks over where blacks lived, one street. That's what I grew up with. I never saw an Indian person, never saw a Muslim person, never saw, but I've seen every race and tribe in my practice. And I can tell you, every race and tribe is uniquely wonderful. And if you haven't understood that, if you haven't come to realize that, you can join. There's lots of groups that are going to tell you, you are right. It's all about white. White is right. But I can tell you, you just have to meet people. You have to meet these groups to appreciate how every race and tribe brings a unique, complete, wonderful flavor. I mean, again, half my practices have been African Americans for 30 years, and I've learned so much about life from them that I would never have learned from someone in a different situation. So, but here's the thing, is this a disease of old men? This is not a disease of old men. If you screen, you find them 10 to 15 years earlier. And the greatest benefit of screening is between 55 and 65 years old. That's not old age, especially now. You half the 55 to 65-year-old people I see are in amazing shape. They don't look 55. They look 45. African Americans, the best benefit is 45 to 55. So this is not a disease of old men that you can write off and say, you're going to die soon. Why are you screening? This is what I said earlier. You can completely change the story of these lives by screening. So, it's a disease of middle age when screening is optimized, and so, but what are the barriers to prostate cancer elimination? We have to overturn the task force recommendation. Something very fishy. I don't care if we get to the bottom of it and find the crime at the bottom of it. I just if they come out and say there's all this overdiagnosis, we got to stop screening. I hope the Congress, I hope everyone involved says this is an atrocity and works to turn it over. Primary care, obviously, I did internal medicine before I did this. I, these people are smart, but all they did is follow orders. The task force said stop screening. They did it on the thinnest of evidence. That's a disgrace to our whole family practice internal medicine core. So I have a solution that I'll present for that. Age bias obviously must be addressed, but the first way to address it is this is not a disease of old men. This is a disease of middle age when properly diagnosed. And race bias, well, that's an old story in our country. It's going to take another generation or two to figure that out. So what I did is put together a website. This can get your family doctor up to speed. It's about an hour and 15 minutes. And all you have to do is say, go to PSA4050.org, and he can pull this up, and it's about an hour and a half. There's questions. You can get CME credit very soon. It's a lot of work to get this turned into a program, but they all need CME, continuing medical education. So I would just tell you, if you're seeing your family doctor, get send them this PSA 4050, and if they come back and say PSA screening is worthless, as some family doctors say, then find yourself a new one, because they're not understanding how critical this is, but this will educate them. And if they do it, they get this cool patch. Jim, I don't know if you got that patch. I sent a bunch of these patches to you. You might have to distribute them next week. Very cool. PSA 4050 means black should start at 40, whites at 50. And this has been lost entirely, right, in screening. So a very important thing. So conclusion, PSA screening can reduce mortality by 90%. There is no such thing as overdiagnosis. There is overtreatment. So hold your questions. I don't know if there are questions. If you have burning questions, we could take a little break, but I think I was trying to get this to an hour. How can we treat people, keep all their functions intact? So we have a 54-year-old with high-risk cancer, and you can see his PSA was not that high, but he had Gleason 8, both sides, and he had T3A, which means you could feel it sticking out the side of the gland. His MRI showed it was outside the gland, and here's his MRI. You can see this tumor sticking out the side. The prostate is here, tumor's there. On another view, anyone could, the man in the street can read this scan and see that tumor is outside the gland. And then this is another version. So how MRIs work is they layer these different versions to see where the tumor is. You can see the tumor plain as day, and then what I do is sphincter length. If the sphincter is over a centimeter, you have a low risk of incontinence with surgery. So this guy on the sphincter side, he could do surgery. He's not going to have incontinence, right? And what happened? Well, long story, he should have had combination. I told him that. My colleague at U of M, who is defiant and really hates combination therapy, saw this couple, talked him out of it, and then they came back to me and said, can you guys get your proverbial S together? He said different thing than you do. This is U of M, for God's sake. Why can't you agree on this? And I cannot defend it, to be honest. So they went over to surgery, heard a surgical opinion. Well, you can't cure disease outside the prostate. So I kind of tried to make amends and say, you can have surgery, but you're going to need radiation because this cannot be cured with surgery. But they went for surgery, and sadly, even though I told him right before he went for surgery, the one thing you got going for you is your sphincter is long. You're not going to have incontinence after surgery. He was part of a protocol he signed up for where they were doing like Mohs surgery, like skin tumor, where they keep going, keep going, keep going till they get a negative margin. And look what happened. They basically excavated the entire sphincter. He came back and he had complete incontinence, like incontinence where he needed a penile clamp to stop from leaking. Otherwise, he's so tragic because this was one of those 55-year-old veranda couple, I call them. They should be on the cover of Architectural Digest with a fancy drink in their hand. Beautiful people. They're buff. They both work out. They look like again, Stepford wives and Stepford husbands. I mean, and it's so sad because he's got a clamp. He's got florid incontinence and this crazy protocol he got on that didn't respect the sphincter length. But it's sometimes we fail, and we fail even though I gave him all the information. I said, you're going to need radiation. But instead, someone had this idea that they needed to excavate the sphincter. So I don't think we've completely sorted this out. I can tell you that every patient that I ever see believes surgery is better. It's psychologically the obvious better choice. It was not the right choice for this man, but he got to a point where, you couldn't talk him out of it. So these are the two schools of thought, though, that create so much problem. This is the conflict between my colleague at U of M. I've always been brachy beam combination, less hormone therapy. He's a big advocate, 18 months of hormone therapy and beam. And these are the two recommended options on the guidelines. But what we know now is a trial that says you can do 6 months and you'll do as well as 30 months of hormone therapy. This is a landmark. Just write this one down. It's called TRIP. Basically says if you get aggressive enough treatment, then you don't need 2 years. You don't need 18 months. You get the same benefit from 6 months. So that's a staggering difference because if you talk to people at 6 months in the play I wrote and included, you can look at it. There's one couple that's at that 6-month break point and, they're desperate. Wait a minute. If we go another year, what's going to be left of this guy? And so, 6 months, anyone can tolerate. So a lot of infighting. You saw the tragic consequence in this patient. And now I get demerits at U of M because they're very staunch advocates that everyone with high-risk cancer needs 18 months, even if they do seeds plus beam. And this is, a long, sad story. We've fought it out, and I have lost. I get demerits now for giving 6 months. So, a lot of infighting, but a randomized trial like that really does change the world, right? if you have bad high risk cancer, you're gonna have eventually in the guidelines the option of 6 months plus aggressive radiation versus 18 months with less aggressive radiation. And I'm telling you, 18 months of hormone therapy is a huge burden. So this though, what are we talking about? This is 18 months. So they'll tell you this is statistically significant. So if you get 18 months of hormones, that's the red line. If you get 6 months, that's the blue line. So if anyone here says, oh my God, look at that. It's an incredible, that is a statistically significant difference. That if you're at 6 months and at your wit's end with hormone therapy and you see this, you're going to say, I'm done, right? It's not a big breathtaking difference. So what about combination? Combination has what we call a plateau. It's cure. It's a cure plateau, meaning you drop down, a few people fail, and then it's forever and ever no failure. So if you look at these two, this is overlaid of the beam plus 18 months. This is the combination therapy with a variable, admittedly a variable amount of hormone therapy, but there's no comparison between these two, right? That's that's a cure. This is going down for as long as you follow. So, a lot of men are getting 18 months of hormone therapy. They're going through the ordeal of their lifetime and they believe they're on the path to cure, but this does not cure. And so that's a drastic, unbelievable night and day difference. So we want to limit ADT. It's the most devastating treatment we administer, not just sexual function. You lose your libido, your penis shrinks, all kinds of bad things happen. But really, it's more aging, decrepitude, dementia. It's like in a bottle. It's old age in a bottle. When they did a comparison in England, men who are on ADT matched the quality of life of men dying of prostate cancer. So that is very sobering. I think you don't want to jump on this casually for 18 months. Most would agree that 6 months is tolerable, beneficial. Uh, but again, there's a suicide risk with that. Some guys get depressed. I've had two patients in my practice. So you want to try to limit ADT. If you have metastatic disease, that's a whole different thing. These are miracle drugs. If you have metastatic disease, you can control it for years. But there are ADT widows, and I have to tell you this because I had a man come in a year out looking great. I said, man, you're doing great. And his wife said, Dr. McLaughlin, I want to tell you something. I still remember her voice. I've been married to this man for 30 years. In all of that time, he never said an unkind word to me. In the last year, he's taken my head off on multiple occasions. I don't even know who this man is. He is mean. And I turned to the man. He kind of shrugs his shoulders like, can't help you, man. It's no big deal, right? He just, another widow too, has almost Cary Grant for a husband. They go out for these walks. They talk about their grandkids. They talk about we're going to Europe, we're going to Chicago, we're going everywhere. He's entertaining. He's the life of the party, the funniest guy. And she's married to him. She's madly in love with him. And then she's with me and she points to him and says, what is this? Right? What? This is not the guy I've known for 30 years. And yet I asked him, how are you feeling? He said, I don't know what she's so upset about. Nothing's bothering me. And the problem with hormone therapy is it's like personality annihilation. Nothing's bothering me. I'm okay. But you're mean, you can't remember anything. It's like there are many devastating effects of long-term hormone therapy that you have to be mindful of. But to know what's going on, you probably have to talk to the spouse. And I think you learn way more of the picture when you talk to the spouse. So lots of, and if you want to know this, if you want one fantastic, some of you know This American Life, it's a radio show. All you have to do is Google This American Life testosterone, and it's a fantastic radio show for an hour that kind of goes through this in gory detail. So But what about this? Having trashed hormone therapy to the death, what do I do now? I'm going to turn around and say it's the greatest thing in the world for short term. This is a terrible tumor sticking out the side of the prostate, growing all the way through. Look, it's growing into the wall, pelvic wall, and this is the same tumor 4 months later after ADT. It can just collapse these horrendous tumors back into the gland, and it does it right away. That's an unbelievable effect of an infinite value. So I don't want you to get the impression that I never use hormones. I think hormones are fantastic, but you have to limit the duration. And if you're one of these guys that feels absolutely terrible, massively depressed, you have to stop it. And there are alternatives. So what's happened in the world now, we don't have the two silos. Now we have tumor boost treatment. So instead of this war of you have to do brachy beam versus long-term hormone. Now you can do short-term hormones and you can do tumor boost. And this is very famous trial. I don't want to kind of gory detail with this, but basically about 10 years ago, it was possible to see the tumor, the bad tumor in your prostate. What this group did is decide to boost that with beam radiation and basically eliminate that tumor through the high dose. They didn't give high dose to the whole prostate, which has toxicity. They just blasted the tumor, and this worked fantastic. But what's interesting is, again, we see the same thing. A lot of the patients, 50% had 6 months of hormones. 30% had no hormones at all. So if you intensify the radiation, especially if you concentrate it on the tumor, you don't need the hormone therapy as much. But none of the tumors on this study got full dose because the rectum was in the way. I have a paper that we've just come out with, gel-enabled dose escalation, that basically says if you get thick gel, and we've kind of mapped out how to do that. It's like our technical papers. There's a way to get very thick gel so the rectum is, the prostate's here, the rectum is here. And what happens when you've separated that is you can give seed level dose uh, without seeds. So our big battle with beam guys is kind of over. You can deliver seed dose, and I'm sure that will give you a fantastic result. So there's some technical things. I don't want to get bogged down with that right now, but there are some great solutions for this. I'll just end though with vessel sparing, and what we found is that at 10 years, there was no difference between function at 10 versus 2. So every surgeon you see will say, well, with radiation, you start good with sexual function, but then it keeps dropping and dropping and dropping and dropping. And it just wasn't true. If you spare these structures, it's very, very durable. Can't go into the detail here. We could kind of go through this another time, but it was at 2 years, 85% had good erectile function. At 10 years, 75%. That's a tiny drop. To say 3/4 had good sexual function that far out is a major accomplishment. So finally, elimination. Let's look. Remember, I told you, remember that 90% in the pre-PSA era, 90% of men with high-grade cancer are dead. That's here. This is the result with aggressive prostate cancer. And with screening, obviously, these men had PSA screening and aggressive cancer. And look at where we are. It's 90-90, right? 90% were dead in the pre-PSA era. Now 90% have no evidence of disease at 10 years. I mean, you should be shocked in a good way by that. So you start back in the pre-screening era, 90% would be dead. Now you have 90% alive with no Mets at 10 years. So kind of an amazing turnaround. But this is what I mean by prostate cancer elimination, right? This is death from prostate cancer. This is rare death from prostate cancer. If you sync up these things, and it's not mysterious. We don't have to crazy, all kinds of ramifications. You just screen people. White men should be screened at 50. Black men should be screened at 45, unless they have a family history, in which case they get screened at 40. And that's it. It's way too simple to imagine. But if you do get a cancer that's bad, you need to treat it aggressively. So I appreciate it. And I have a website that's I've been writing things over the years. I have a healing arts program. That's the art part. Not7.com. You can find Not7. I got music in there, healing arts, prognosis, poetry. The Gleason 7 is the part you're going to be perhaps interested in. This is all the resources for aging men, right? Prostate cancer, medicine and the great soul, and the human drama. The human drama includes this play. And I'd really appreciate it if you could look at it. This is kind of a Broadway style play. There's a bedroom scene, there's a living room scene, there's a doctor's office scene, and these couples rotate through, and the script is right there. There's three couples. They kind of rotate through before they're diagnosed, at diagnosis, and then after treatment. And it goes through in kind of gory detail. The problems up here, this is the support group like you have tonight. Only guys get up and they kind of tell everyone in the group, they share their experience, only it's in song. And these are almost transcripts from my practice, these songs. So they're pretty edgy, but I think it's a very powerful way. I'd be just curious, because if I tell you, well, 20% of people have incontinence, or 20% of people have very limited erection function, that's just a number. But if you put it in a couple, in a drama, you will feel it in a completely different way. And I think that's the way we're going to have to convey the implications of all of these treatments. You're going to have to see a couple go through it, and good, bad, or indifferent, it makes a big difference. It's not a number anymore. It's a person, and it's a couple, and it's very real compared to most of the stuff you hear in a talk with all kinds of numbers and graphs and this, that, and the other thing. Very memorable when it's right in your face. So have a look at that. I'd appreciate any feedback. You can just write me at my standard. Jim has my regular email, and I think that's it. Really appreciate it.